So we've had a couple of areas of response, both state and nationally. There is an asthma initiative of Michigan. It's not an overarching coalition, which I believe you have here in Maryland. You have an asthma coalition for the state. We don't have that. We have about 10 different local coalitions, but we join forces to work on some statewide initiatives, but it's not an overarching coalition. And we have formed this consortium of all the Michigan asthma coalitions, and we have a great website. It's called getasthmahelp.org, and it's a wonderful resource for health professionals and patients alike. You can download all kinds of patient education tools. You can find out about statistics, more information on the guidelines, so you might find some benefit there. Also, anybody here attend the US EPA Asthma Forum a couple weeks ago in DC? No? Okay, Valerie was there. They have an annual National Asthma Forum, which is a wonderful resource as well. And they've created a website of asthma programs nationwide. It's a repository of all the collective wealth of knowledge about asthma programming nationwide. It's called asthmacommunitynetwork.org, and that's a wonderful, wonderful resource as well. So if you're just wondering, is there another asthma program out there that's doing X, Y, or Z? There probably is. So you can tap into that great network, and you don't have to reinvent the wheel, because people who sign up for that network want to share information that they've been able to provide over the years. So feel free to contact anybody that you find. There's hundreds of asthma programs that are now registered in that network. And then, as I said, the National Asthma Educator Certification Board. We have about 125 certified asthma educators in Michigan. I forgot to look up to see how many there were in Maryland. But you can go to our website and pull up your state, and you'll see how many they are and where they're located. So the Asthma Network, the local asthma coalition that I manage, has two overall goals. One is to serve as a community educational resource for professional and lay public, and that's through our Speakers Bureau. And then case management of children and adults with moderate to severe asthma, predominantly from low-income families. So that's our target population. These are folks, mostly children, and these are mostly from low-income families. Most of them are Medicaid eligible, and that's really our heart and soul of who we want to serve. Now, we do see some adults. We see some individuals who have commercial insurance or have no insurance, but we really target the children with uncontrolled asthma. So our case management services are unique. It was interesting when I went to the EPA Asthma Forum. They're not quite so unique anymore. There are a lot of other programs that are cropping up around the country that are doing home-based case management. It really is becoming almost a model that a lot of programs and communities are adopting, because it just makes sense. If you think about it, you're going to where asthma lives. And we always tell providers, we are your eyes and ears in the home. When we go into that family's home, they may tell you that they're not smoking. We can see the mounds of cigarette butts in the ashtrays, and they may tell you that they're using meds that they don't even have access to. So we really are able to bridge that gap between what they hear and see in the provider's office and what we hear and see in homes. Just a real quick example. One of my case managers came to me and said she got a phone call from this young girl's primary care provider. And this physician said to her, I'm going to discharge this patient. I'm going to discharge this patient from my program. I'm going to call Child Protective Services. The guardian, the grandmother, is not administering the daily controller medication. So she's been suffering as a result of that. And Joyce, the case manager, said to her, before you do that, let me just make a home visit, find out what's going on in the home. So she made a visit, and she asked this guardian, this grandma, do you remember getting a script for this medicine? Happened to be an inhaled corticosteroid that's administered via a nebulizer. And she said, oh, I do. And she ran upstairs and brought down the box. It had been opened. She'd used some of the vials. She said, well, of course, what's the standard asthma educator question? Show me how you use it. When do you use it? She said, well, every time she coughs, so right there, using it inappropriately, using it as rescue and not quick long-term control. Every time she coughs, I take out a vial, I open it up, and I put it in her vaporizer. In her vaporizer. Now, someone probably said to her in the physician's office, do you have a machine for this? And the grandma probably thought, oh, sure, I've got something that would run that. So she's vaporizing this inhaled corticosteroid instead of obviously nebulizing it. Now, had we not uncovered, and that's just a very small, minor detail, but had we not uncovered that, imagine the consequences of that child. They probably would have been discharged from the practice. They probably would have had Child Protective Services called in. They probably would have filed charges for medical neglect. I mean, just the whole cascading of events that would have taken place, where it was just a really easy fix by just identifying what's happening in the home. What's going on here? Show me what you're doing. Tell me, explain to me, teach me what you're doing. So the home visits for us are just fundamental. They're just so crucial. And in addition to that, we also make school or daycare visits, depending on how old the child is. So we will go, again, to where the child lives during the day, and we'll work with the schools and the daycare centers so they understand asthma there. We also conduct a care conference with the primary care provider and or specialist. So it's usually with the family present, and help develop or squeeze out an asthma action plan. I love that tool. And we also have medical social workers who will assist with psychosocial barriers, and I'll explain those in just a minute. So our staff consists of asthma educators and case managers. So we have about 3.5 full-time equivalent asthma educator case managers. When we hire them, they either have to be a nurse at the RN level or a respiratory therapist at the RRT level, usually with some interest or experience in asthma themselves and asthma management. Many of them have asthma or have children with asthma or just have a passion for asthma. They must be a certified asthma educator when we hire them. If they're not, they must sit for the exam within a year of employment and pass the exam. And we will pay for them to take a review course, we'll pay for them to take the exam itself, and then we'll pay for them to recertify every 7 years, because that's a requirement of their job. I'm the full-time manager. We also have 2 full-time social workers. These are licensed master's social workers, and they are prepared in medical social work, and they have extensive knowledge of community resources. I'm sure just like Baltimore, we sit in a very resource-rich community that individuals just aren't aware of and are not tapping into, and that's where the social workers connect the families to these wonderful resources and help support them. We also have a full-time clerical staff, and she does the billing for the insurance companies, and she assists with scheduling appointments, correspondence. She helps complete and maintain our database. So the goals of our case management program are several. One is to target behavior modifications and promote prevention rather than crisis care. We also encourage appropriate utilization of the healthcare system in order to decrease inappropriate ED use. Access to medications and primary care physician. We help them obtain a medical home if they don't already have them. And we address barriers. We encourage problem-solving strategies. And any of you here doing home visits? A couple of you? So I'm preaching to the choir. You know that when you're going to these homes, sometimes asthma is the least of their problems. You know, you're going into these families, and until asthma bubbles up and becomes a priority, and they end up in the emergency department or they end up in the hospital, sometimes they're just living from crisis to crisis. I don't make visits now anymore, but I used to make visits as well. And there was a family I was visiting, and the young man had severe asthma and was having frequent trips to the emergency department and hospitalizations. I got a call from his physician, and she said to me that she was dismissing this family from the practice because of noncompliance. And I said to this physician, I said, "Do you have any idea what's going on in that home?" And she said, "No." I said, "Well, Dad was just incarcerated. They are going to be homeless. They're in crisis." And she said to me, "When's your next home visit?" And I said, "Well, it's tomorrow." She said, "Well, do you mind if I go with you?" I said, "Okay." And I called the family, and they agreed to it, and picked up the physician, and off we went. And I could tell she was kind of gearing up for a fight. I'm going to lay down the law. They're going to understand why they need to take these meds, and we're going to make sure that everything's squared away. Well, when we got there and the mom started telling her story, you could just see the whole demeanor change for this physician. And Mom was talking about going into the shelter, and suddenly I heard the physician say things like, "I prescribed this medicine for your child that's supposed to be taken 4 times a day. Well, that's not even realistic at this point. Let's switch it to this one that's taken twice a day. And right now, you're getting your scripts filled at this pharmacy here, but you're losing your car next week, so you will have no transportation. Let's switch all of your meds to this pharmacy over here that will deliver to you in the shelter." And the whole visit went like that. It really became more of a partnership. And we walked out of that home, and the physician turned to me and she said, "I had no idea. I had no idea. How could she possibly have known those things?" And I don't expect every physician to make a home visit. Certainly that's not realistic. But that's why we're the eyes and ears in the homes and can share some of those concerns, those issues that come up, just real life experiences. Because, you may go into a home and asthma is number 20 on their priority list. We have social workers making home visits, and usually we'll have the case manager, the nurses, or respiratory therapist going into the home first. They'll open up the case, sign the consents, we'll do a Juniper quality of life scale in the first visit, asthma control test, some of those basic things that we're measuring first. And then they'll continue to follow them up for several weeks to months to give them, there's a set lesson that we give them, about 6 different lessons, and then follow them after that. And sometimes we will always offer the services of a social worker on the first visit if they have any psychosocial needs, Well, sometimes the social workers will take the first 4 visits because a family is in crisis and they have no food, they have no diapers, they are going to be homeless. There's just, I walked into a home once and the mom was suicidal. You never know what you're walking into. So once those basic needs are met, it's like Maslow's hierarchy of needs. Once those basic needs are met, then the asthma educator can come into the home and start talking about asthma. But if you try educating a family about asthma and they're hungry, it's going to fall on deaf ears. So we really need to identify what's going on in that home first and help them meet those basic needs first and then move into asthma education. So we help them and we encourage problem solving. We don't just say, well, let's call the physician and make your next appointment. And sometimes they'll say, well, I don't have a phone, I don't know what to say, and we'll walk them through the steps instead of saying, well, let me just do it for you. We also try to improve asthma knowledge, improve quality of life, and resolve the multitude of psychosocial issues, as I just spoke about, that allows the asthma educator to focus on asthma management issues. We help enhance communication with school and medical personnel, and we also help ensure asthma management in accordance with the national guidelines. We're not in the homes to provide treatment, and we don't want to compete with the primary care provider. We're not providers in that regard, but we will meet, when we meet with the provider, we can say things like, did you realize that this child is having trouble this often at night or is using their inhaler this many times during the week? Would you not consider them a candidate for an inhaled corticosteroid? Because there are things that they may not be aware of. The program is designed as 12 months of case management, and that allows for adequate follow-up, reinforcement of education, and the seasonal changes that can be pretty dramatic in Michigan anyway. We do provide baseline assessment and goal development, and these are mutually set goals. We're not coming into the home and assuming that these are the goals that we have for your asthma management. What are your goals? What do you want to accomplish? What do you want most? What's bothering you most about asthma? We provide an environmental assessment, and so we'll visit, obviously we're in the homes anyway, but we'll visit the sleeping area, the bedroom or living room, wherever that child sleeps, so we can identify any triggers we might see there. We make sure that they are plugged into good medical education and care. And then, as I said, the psychosocial interventions that the social workers provide for us. And typically, visits will occur bi-weekly for the first 3 months. We have a set of about 6 lessons that we'll teach over 3 months. And then monthly thereafter, or if there's been an exacerbation or an encounter, or the physician calls us and says to us, can you get back in the home? I'm concerned, I've heard this, I've seen this, I wonder about this, and we can do that as well. Or the child was just in the emergency department, we'll make a more urgent visit as well. And the care conference then is conducted with a primary care provider, sometimes a specialist in addition to that, with or without the family present. Most often it's with the family. We will accompany the family with prior permission from the provider to a clinic visit, to an office visit. And the goal of that is not to have the asthma educator interfere with the process of a well child or an urgent visit, but just to almost function as a fly on the wall and observe everything that's going on, and then helping reinforce what they're hearing in the provider office back in the home, but also sharing some things that they might have heard in the home the provider might not be aware of. The goal of that, again, is to elicit, squeeze a written asthma action plan out of that provider, discuss compliance or adherence issues, and then discuss access to care issues. So can they get to the visits? Do they have transportation? Do they have the devices that they need? Do they have the medications they need? Do they understand the medications? Are they taking them appropriately? This is a reimbursed visit for us, as well as the home visits from the health plans. They will pay for as many care conferences as we need to conduct for that child. In addition to that, we visit the school or daycare, and we schedule a visit. Sometimes we'll offer a visit to the school, and we'll talk to the principal or school nurse, and they'll say, there are so many kids in this school with asthma. Could you just come in and do an in-service for the entire school? And we're happy to do that, but then we'll discuss that child's issues in private. But oftentimes we'll meet just with the key cluster of individuals who are responsible for that child throughout the school day, and that might include the nurse, the classroom teacher, phys ed teacher, school secretary, principal, especially the secretary, because I don't know about here in Baltimore. In Grand Rapids, we're very fortunate. We have about 30 school nurses that are in most of the Grand Rapids public schools at one point or another. But otherwise, in all the other districts, there may be one nurse for an entire district of thousands and thousands of students.